Welcome back, everyone, to our first Ocular Melanoma Symposium, Day 2. For those who are joining for the first time, my name is Jasmine. I'm the Managing Director here at Save Your Skin, and I will go ahead and introduce our host for today in just a moment. But before I do, I just want to go over some Zoom housekeeping rules with you all today. That's everything from me, so I am going to pass it on to Kathy Bernard, who will kick off the symposium for us.
Thanks, Jasmine, and a big thank you to all of you who are joining us on day 2 of our symposium. For those who missed yesterday, my name is Kathy Bernard, and I am the founder and president of Save Your Skin Foundation and co-creator of Ocumel Canada. Today, we have another packed day with some patient stories, a presentation by Dr. Marcus Butler, and a live presentation with an interactive portion with Monica Tam. Now, let me introduce you to my good friend, Nigel Deacon. Over to you, Nigel.
Thanks, Kathy, and welcome back to everyone for day 2 of our symposium. Our focus today starts with a session on metastatic ocular melanoma. As we all know, this is a very serious topic, and if things feel too heavy for you, feel free to take a little break whenever you want. You can always catch up later, as we will send the videos to everyone who is registered. Come back whenever you feel you are ready. If you tuned in yesterday, you will know that my ocular melanoma metastasized in 2012. That's 11 years ago now. And I'm very fortunate to have survived to talk to you today. I fought to get treatment when none was available. I went outside Canada for advice and a sense of direction because I had to. There was no advice available here. Today, you will learn that we are in a very different situation now. In June 2022, the very first treatment specifically for metastatic ocular melanoma was approved by Health Canada, and I am sure that there are many patients here today on that treatment. A warm thank you to those of you who helped us by participating in Immunocore's application to Health Canada, and we hope you will help us many times in the future as new treatments seek approval in Canada. The door is finally open, and there is renewed hope that we can live with this disease. Save Your Skin Foundation and Ocumel Canada worked hard to make sure that patients all across Canada could receive this new treatment close to home after they had gone through that first difficult 4 weeks close to a hospital. Now let me introduce you to Candace. Candace lives in Toronto, Ontario. She worked in real estate for 25 years, and she was diagnosed with a ciliary body melanoma in her right eye in 2017. In January 2021, shortly after retiring from her career in real estate, a metastasis was found on her liver. Candace loves spending time with her family, has been an active volunteer for many years with a local Canadian dog rescue, and is passionate about animal rescue adoption. She enjoys nature and wildlife, birding, traveling, hiking, cooking, and baking. Candace?
Thank you so much, Nigel, for that wonderful introduction. And thanks to everybody in attendance today. We have quite a packed agenda, and I hope you'll stay with us until the end and participate in our interactive discussion. So as Nigel had mentioned, my name is Candace Charles. I live in Toronto, and my original uveal melanoma diagnosis and subsequent treatment with plaque brachytherapy was in June of 2017. A tumor sample was sent to Impact Genetics for genetic profiling, and the results were high risk to metastasize. The results were specifically monosomy 3 with 8p loss and 8q gain. So that was the first time I had ever seen medical jargon like that. And so began an obsession to Google what it meant, what it could potentially mean. And after hours and hours and days and months of Googling, I learned essentially that I could be dead within a year if this spread to my organs. So I did my best to stay positive, which really was quite difficult. I was very anxious. My scanning protocol was set up with MRIs every 6 months and CT scans annually. And I went about my business. I had led a very healthy lifestyle, but I really upped my cardio and running game. I had been running for probably 25 years at that time. And I just had this idea in my head that if I could do enough cardio and sweat enough, my body would get all the toxins out, and that uveal melanoma would never take hold in any of my organs. So imagine my surprise when on January 10th, 2021, I received my MRI report in my portal, and it mentioned an interval increase in a segment 6 hypervascular lesion measuring 1 centimeter, suspicious for metastasis. And yes, you heard that right. I had no idea there was an existing lesion. My MRI from 6 months prior in July of 2020 said, and I quote, "No definite liver metastases are identified, no liver metastases." So back to January 10th of 2021, there was an interval increase in the existing lesion plus a new hypervascular lesion in the same segment, suspicious for Mets. And the impression was new small liver lesion plus interval increase in size in pre-existing lesion, both in keeping with metastases. It's such a shock. It's such a blow when you see it with your own eyes. I knew it could happen, but there's just, you could have literally knocked me over with a feather. It is just a really heavy, heavy blow. So now the real, I don't want to say journey. I don't love using the word journey for myself. I know it's probably a great descriptive word for other people, but really I call this whole cancer thing a catastrophe. My cancer catastrophe really kicks into high gear because I had learned via Google that if this spread to my liver, I would be dead within about a year. So I'm happy to say that Google really hasn't kept up with advances in uveal melanoma metastasis treatment, because I'm still here. And if you go by the July 2020 date, I've actually had metastasis in my liver for almost 3 years now. And I'm still on my first line treatment, which I'll talk about in a moment. But the biggest thing that I really want to emphasize is the worst part about the whole diagnosis has got to be the stress. The fear is overwhelming. The anxiety is I can't even think of a stronger word than overwhelming. It's something that is with you 24/7. It never really leaves you. I do a lot of things that I enjoy, and I have breaks from the overwhelming anxiety, but it is just, there's always an undercurrent of, when will my treatment stop working? Oh my gosh, is that new pain? Did it spread? Look at this new bump on my arm. Is it a mosquito bite or is it a subcutaneous Mets? Like, it's a never ending, awful anxiety provoking situation. Anyway, after the Mets diagnosis on paper, I had to go in for a biopsy, and the first attempt at the biopsy was actually aborted. So I was all ready. I was there on the table, and the radiologist, she couldn't get a clear way to the tumor. It was really close to my colon and also a kidney, I think. So I was sent home, and I had to wait for this thing to grow, which had already been growing since the prior summer. That almost was a blessing in disguise, not knowing, because it was really hard to go back and then wait for the biopsy to occur. It was scheduled for late February, and I was really happy to see the same interventional radiologist, because I knew how careful she had been, and she looked and said she could definitely get a sample. And she did get a sample that was enough to confirm uveal melanoma metastasis, but it wasn't enough for any type of molecular profiling. However, my amazing oncologist, Dr. Butler, who's going to speak right after myself, he had run a trial, an IMC GP 100 trial, which if you're familiar with tebentafusp or Kimtrack, that's what it was called in the beginning days. So his trial, I had missed the cutoff for, but he actually applied on my behalf to, under our special access program, he applied to Health Canada for compassionate use of the drug. And that was a long process. I was the first person in Canada approved for compassionate use. I didn't actually start treatment until mid-June of 2021. So by that time, I was starting treatment with about 8 measurable lesions, all fairly small, maybe no bigger than a centimeter and a bit. But I started in June and did the first 4 infusions inpatient. The side effects were really tremendous. I call them really, really severe. And my doctor called it a very robust response. So he definitely has a way of mitigating the fear. It was a really severe reaction, head to toe rash, crazy edema, among other things. But anyway, it's short-lived and really well tolerated. I've been on this drug now for almost 2 years, keeping things more or less at bay. My first scan after being on tebentafusp for 3 months showed what I thought was progression, because every tumor, the measurements were larger. And I was devastated, just completely devastated and mortified. And I remember calling my doctor's office like crazy and spoke to him shortly after I had been leaving messages, and he wasn't concerned at all and had told me that he had seen this in many of his trial patients. He didn't believe it was true progression and just stay on the drug and scan again in, I can't remember if it was 2 months or 3 months. I think it was actually 2 months, just to make sure. And of course he was correct. My next set of scans and then all the scans subsequent to those, everything's been stable to very, very minimal growth. So he was correct, and this definitely is working well for me. Even though it's working well, it doesn't mean that the emotional trauma isn't still there. I really find it very difficult to deal with. And hopefully you'll tune in after Dr. Butler's going to speak. We have a social worker from Toronto who's going to speak to the psychosocial aspect of this, because it's really huge. And I don't often speak about this, but as I'm talking about my story or my cancer catastrophe, it's such a huge part of it. And it's a constant struggle. Really, all the time, it's a constant struggle. So I sort of exist in this space that's like, if hope is here along this straight line, sometimes I'm here and I'm a bit hopeful, and a lot of times I'm here. I'm never down here. I haven't really entered a great debilitating depression, but I'm sort of existing a bit here. And I've really had to train myself as I'm watching fellow patients and friends that are being taken down by this brutal, evil disease. I'm making sure to focus also on those like Nigel, who's definitely an outlier, but he exists. He's had metastatic disease for 11 years and is still stable. And he's not the only person that I know in this amazing situation. So there's definitely hope. And Nigel's definitely proof of that. So, and even my own story, so I'm so thankful Google was wrong, because if I've had metastatic disease in my liver for the past 3 years almost, 3 years is pretty good. I didn't think that I would be here in 3 years from everything that I had read. So great advances have been made and continue to be made with respect to this. I'm still on tebentafusp. Unfortunately, my last scan, which was only about a month ago, on March 12th of this year, did show progression. It showed that some lesions are growing, and there's one in particular that just seems to be a rogue lesion. And I spoke to the interventional radiologist, who mentioned a couple of different treatment options. None of them are ideal, ablation or radiation, just because of the proximity to the colon. So I'm kind of wondering if there's that first lesion that came up that was so close to my colon. But in any event, I am hopeful enough and confident enough that it will be dealt with, it will be taken care of, and hopefully I will continue to stay stable on this drug or move on to the next when the next comes, hopefully during my lifetime while I'm around for it. So amid the constant struggle to deal with the fear, and the anxieties, there's definitely hope for me. And on that note, I'm going to introduce you to the amazing Dr. Marcus Butler. It's my honor to introduce Dr. Butler. He will now be presenting on ocular melanoma in a metastatic setting. And Dr. Butler has recorded his presentation for us, and he was able to do a Q&A with some questions that we had gathered prior to today. So Dr. Marcus Butler is a medical oncologist and the Medical Oncology Melanoma and Skin Oncology site lead at the Princess Margaret Cancer Centre in Toronto, Canada. He is a physician investigator interested in the translational development of immune-based therapies for cancer patients. He received his MD from Yale University in New Haven, Connecticut, and trained in internal medicine at Johns Hopkins in Baltimore and hematology oncology at the Dana-Farber Cancer Institute in Boston. After serving on Dana-Farber staff, he joined the Department of Medical Oncology and Hematology at the Princess Margaret Cancer Centre in 2012. And I speak on behalf of many, many people. We are so very fortunate to have Dr. Butler here in Canada. Dr. Butler is the Medical Oncology Disease Site Lead for melanoma and skin cancers at Princess Margaret, and he is also Assistant Professor of Medicine at the University of Toronto. He's the Clinical Director for the Immune Monitoring Team at the Princess Margaret Cancer Centre, where he focuses on the immunologic impact of anti-cancer immunotherapies. Dr. Butler has been a great resource and a very good friend to Save Your Skin Foundation for many years, and we are so pleased that he is the co-lead of the Ocular Melanoma Physician Task Force of Canada. And now over to Dr. Butler.
Hello. Hi, my name is Mark Butler. I'm very pleased to talk to you today, and thank you for the opportunity to speak with you. Okay. Today, I'd like to speak to you about metastatic uveal melanoma. As I said, I'm Marcus Butler. I'm a medical oncologist at Princess Margaret Cancer Centre in Toronto. I work in the melanoma skin oncology disease site, and I work closely with medical oncologists and ocular oncologists throughout the country to try to improve treatments for patients with uveal melanoma. Here are my disclosures. So the objectives today are to define metastatic uveal melanoma, review options for therapy and developing a treatment plan for patients, discuss how treatment of metastatic disease is evolving, and review the current and future clinical trial options for patients. Uveal melanoma, as other speakers have discussed today, is a cancer of the uveal tract. That includes the choroid, the ciliary body, and the iris, which is a bit of tissue in the eye which has melanocytes, which unfortunately in some cases can become cancerous and develop into a problem that is called uveal melanoma. This is a rare cancer, 3 to 6 cases per million per year. It's a unique type of melanoma in that it is unlike cutaneous melanoma. There aren't a lot of mutations in the cancer, and it has many abnormalities in the chromosomes. It also highly expresses a melanocyte antigen called GP100, and that's important because that is the target of a new drug called tebentafusp. On the right here, you see the evolution of uveal melanoma. Initially, a melanocyte might develop a mutation in a molecule called GNAQ or GNA11. This results in a precursor lesion or freckle or nevi, which then, after additional mutations that develop, can result in the ability of the cells to grow and to spread to other parts of the body. So while there aren't a lot of mutations that are present in uveal melanoma, there are classical ones, GNA11 and GNAQ, which are unique mutations that are only seen in a rare number of cutaneous melanomas, but is very common in uveal melanoma. BAP1, which is a mutation present in more aggressive uveal melanomas, EIF1AX and SF3B1, which are associated with better or slower growing disease. And this is another figure that describes how there are these initial mutations, GNA11 and GNAQ, less common mutations, cisladder and PLCB4 are what we call first hit mutations. And then second hit mutations seem to be associated with some propensity for metastasis and prognosis. Unfortunately, uveal melanoma in 30 to 50% of cases can develop into distant disease. When patients develop metastatic uveal melanoma, greater than 90% of patients will have involvement in the liver, and about half of those patients have liver-only disease. Uveal melanoma, however, can spread to other parts of the body and can be monitored. Previously, standard chemotherapy and immunotherapy had only modest effect, and that resulted in these survival curves that see on the left, where if patients with stage 4 disease, within a few years, a very few percentage of patients were alive. There are ways to identify patients at higher risk of metastasis. In Canada, we use 2 different types of surveillance strategies or analysis of tumors to identify which patients are at higher risk. The strategy on the left uses cytogenetics, where it focuses on monosomy 3 and 8q gain, which are associated with higher risk of recurrence. On the right is the displays the gene expression profile of a type of study called the Castle test, where patients with class 1 tumors are unlikely to metastasize, whereas class 2 tumors are much higher risk for metastasis. It depends on which province you live in, may determine which test is offered. Not all provinces are offering this testing as part of standard of care, so some patients need to pay for it out of pocket. For uveal melanoma surveillance, the majority of diseases of recurrences occur in the liver, and therefore a major focus of surveillance strategies is to look at the liver. Cancer is very able to hide in the liver without any symptoms, so therefore we use imaging to identify metastasis. An MRI of the liver and ultrasound is a very efficient way of identifying new lesions in the liver, and that is our standard practice. CT scans are helpful in terms of supplementing and identifying disease outside of the liver. However, CT scans by themselves will miss small liver lesions. PET scan is also used in some cases, certainly when patient has known spread of uveal melanoma, but it is not a very good screening tool. And that's because the PET scan is not as sensitive for uveal melanoma, where it is much more sensitive with cutaneous melanoma. Basically, in a PET scan, uveal melanoma is less bright than cutaneous melanoma. Unfortunately, in the old days, survival for metastatic uveal was quite poor. Average survival was around 1 year, but I think it's important to keep in mind that these curves are deceptive. First of all, no single patient is the curve. The average patient is the average number, is one person, so that when people are quoted survival of average of 1 year, that means that many patients live longer and some patients live shorter than that period. Also, the older survival curves were performed at a time when there were fewer treatment options, and many of our treatments are now resulting in longer survivals. Also, in the past, we didn't do surveillance as rigorously as we are now, and therefore patients were identified late when symptoms were present and patients were running into problems from their disease. In terms of treatments for metastatic uveal melanoma, there are several different approaches. One is liver-directed therapy. That might involve surgery or ablating a liver lesion, or infusing treatment directly into a liver lesion through a catheter. There are other systemic therapies, which include a drug called tebentafusp, immunotherapy, or immune checkpoint blockade, which is standard offering for patients with melanoma. We can also offer chemotherapy as well as clinical trials. I think it's also important to realize that palliative care therapy is an important component of treatment of patients with metastatic disease. Palliative care doctors can help with symptoms so that you can optimize your life as much as possible during the time you have remaining. It also is a useful strategy to help patients who are on active therapy for mitigating some of the side effects of treatment. But palliative care is also important for making plans for what might happen if your treatment that you undergo is not successful in controlling the disease. So in terms of liver-directed therapy, there are a couple of rules to keep in mind. One is the interval between the eye diagnosis and metastasis. So if you have spread of the disease for more than 3 years after your original eye diagnosis, liver-directed therapy can be considered in patients who have disease that's limited to the liver. Also, other components to consider include whether the patient is having symptoms and whether the disease appears to be small and slow growing, and this might make it amenable to treatment like ablation or surgical resection. Another option to consider is embolization procedures. This includes infusion of radioactive beads or infusion of chemotherapy directly into the tumor mass to see whether we can slow or control the growth of the tumor. Liver-directed therapy for some carefully selected patients can result in improved overall survival, so that the survival curves look much better than those historical curves I showed before, and that you can reduce a progression of disease. Careful selection of appropriate patients is important, since especially now that we have other treatments that include systemic therapies that might offer treatments that can result in longer survival. In terms of metastatic disease, a very exciting treatment is tebentafusp, or its brand name is called Kimmtrak. This is a first-in-class, recently approved drug. It's the first time for a drug to be shown to be able to prolong the survival of patients with metastatic uveal melanoma in a randomized clinical trial. The data best supports first-line use. Also, it's important to know that assessment by a team familiar with tebentafusp is important. Currently, tebentafusp is not funded by the provinces but it is Health Canada approved, and there is a compassionate program. What's involved in assessing a patient with for tebentafusp involves assessing the status of the patient's disease, review of all treatment options, including tebentafusp, and then a special step is HLA testing, where we identify appropriate candidates, and that's about 40 to 50% of patients who present with metastatic uveal melanoma. So tebentafusp is a drug which recognizes peptides that are processed and expressed and presented on the surface of a tumor cell. There are different types of antigenic peptides that can be present in a cancer. GP100 is an example of a molecule which is processed, and GP100 is an example of a molecule that's expressed by melanocytes. GP100 is loaded onto MHC class 1 and then presented to the immune system through something called T cells, which can recognize GP100 through a T cell receptor. And tebentafusp is a drug which has the T cell receptor that's able to recognize the tumor cell, but also on the other end has a activating domain that excites T cells through anti-CD3. This results in a go signal to the immune system to then attack the tumor cell. There were two clinical trials that were conducted looking at tebentafusp. One was a phase 2 study that looked at the standard dosing, which starts at 20 micrograms on the first week, second week 30 micrograms, and then following weeks at 68 micrograms. This stepped up dosing is important in order to identify a dose that's tolerable to patients. And then after the phase 2 was performed with 127 patients, a randomized phase 3 study was performed where patients either received tebentafusp or received standard of care treatment. When you receive tebentafusp, it results in an inflammatory storm or elevation of various cytokines, which then returns to baseline the next week and then continues with multiple doses. You also see trafficking of T cells from the periphery into the tumor so that you see loss of lymphocytes post-infusion. In the clinical trial that was performed, we found that there was a high number of patients with side effects, especially related to rash, which involved itching, redness, significant rash over the face, chest, abdomen, and it can be quite uncomfortable, and occasionally severe adverse events occur in about 15% of patients. Additionally, a syndrome called cytokine release syndrome can occur. This involves fever, nausea, and vomiting, and sometimes shortness of breath. Usually this is well tolerated. However, in about 4%, it can be significant. Because of these side effects that occur in the first month of treatment, patients need to be admitted for an overnight stay and then discharged after assessment the next day. Patients then come back for another dose where we step up the dose and continue this. But once the patient has been on the weekly treatment for several weeks, we find that the significant rashes and cytokine release syndrome are quite minor. Patients will occasionally have some adverse events, but it's very well tolerated and can be administered as an outpatient after the 3 inpatient doses. And what this results in is with this inflammation that's caused with increased cytokines and reduction of lymphocytes in the periphery, is that we see T cells are brought in to the tumor site and will attack the tumor. In patients who have been biopsied, we showed that in all cases, regardless of how inflamed the patient's baseline tumor was, we see an increase in the number of lymphocytes that are able to traffic into the tumor. And we think that this is responsible for the efficacy that we see with these treatments. In the clinical trial, phase 2, we saw a very low response rate, only 5%, but tumor shrinkage occurred in 44% of patients. The phase 2 trial was hoping to see an overall response rate of 20%, and therefore we didn't see this study meeting its hoped for endpoint. However, patients did live longer than expected when you compared to patients with historical controls. And there was also some signal that perhaps the rash was associated with a better survival for patients. So the clinical trial with the phase 3 study proceeded, and we were able to show a significant overall survival benefit in this randomized study. And this resulted in the approval of the treatment for patients. So patients have an overall survival that's much longer than standard treatment. In this clinical trial, patients who received standard therapy had an average life survival of around a year and a half, whereas patients who were on tebentafusp had an average survival of 2 years. And that results in a substantial, statistically significant improvement in survival. And there are some patients who really hit the jackpot and continue on the drug for many years into the future, although unfortunately that is not as many as we want there to be. What's also very interesting about this drug is that even in patients who have progression of disease, we see an overall survival benefit. It appears that the treatment will slow the progression of disease, and that's partly responsible for the benefit patients are seeing. When you do something called a subgroup analysis, we see that patients, regardless of how big their tumor is, seem to benefit from treatment, although smaller tumors seem to benefit more than larger tumors. And this has resulted in a more active attempt to identify patients early when they develop metastatic disease. There's also some indication that there are biomarkers associated with better prognosis, such as inflammatory presence at baseline with CD3 cells. There's also a suggestion that immune cells such as macrophages may be suppressive and hinder the immune response. This is leading to further analysis and development of drugs to try to improve outcomes for patients. In our analysis of patients who live long versus patients who have shorter survival, it appears that patients with smaller tumors do better. And as you can see here in this curve, it appears that the rate of growth in the patients who had longer survival appears to have slowed, where patients who had short survival, the rate of growth of the tumor continues to be high. And therefore, a strategy that looks at the whole of the patient, looking at how well they're tolerating therapy, whether they're having any symptoms from progression of disease, and whether their tumor speed of growth is slowing or not, is important in terms of identifying patients who should continue on treatment. There's also development of circulating tumor DNA as a way to identify patients who may benefit from treatment. And it does appear that reduction in ctDNA is associated with better overall survival in patients on tebentafusp. So you might ask, is tebentafusp the unique or could there be other similar types of drugs that could help in patients with uveal melanoma? Recently, last year, a drug made by the makers of tebentafusp was presented at a meeting in Paris, and they showed that patients who have uveal melanoma could still have shrinkage of the tumor in patients who were tebentafusp naive, as well as patients who were tebentafusp treated. And this new drug that targets PRAME also has promising results in other types of cancers, including cutaneous melanoma. So what does this data about tebentafusp mean? The best option that we know of is tebentafusp in terms of showing longer survival. Its treatment with this drug is difficult at the beginning, but it gets much easier following multiple infusions. And we are currently advocating for a system where patients can have delivery of the drug close to home after the induction is performed, so that a weekly infusion is more feasible for all patients. First line is currently the best option outside of a clinical trial, because that's where the data is strongest. And treatment under the care of an experienced physician is key, and that's because interpreting the radiographic scans is very important to be interpreted in people that are with physicians who are familiar with the drug, and so that all alternatives can be reviewed and discussed at the time of making treatment plans. So standard immunotherapy is also used in patients with uveal melanoma. This comes from the idea that the immune system is able to recognize cancer, and that immune checkpoints can prevent the ability of T cells to attack the tumor, and that these immune checkpoints can be blocked with drugs such as anti-PD-1 and anti-CTLA-4, resulting in a better immune response. Unfortunately, uveal melanoma is a cold type tumor, which is usually not associated with a high response rate to immune checkpoint drugs. And if you see here on this plot, you can see that melanoma, cutaneous melanoma, has a high mutational burden and high response rate to immune checkpoint drugs, whereas uveal melanoma is on the low end. This is also associated with a low PD-L1 score in patients' tumor compared to cutaneous melanoma, which has a high score. And this has resulted in low response rates with drugs like anti-CTLA-4 drugs, ipilimumab or tremelimumab, or pembrolizumab and nivolumab, with response rates generally in the less than 10% range. However, there's also been some work looking at combination immunotherapy. A group in Spain looked at combination therapy. They saw a higher response rate, closer to around 15%, many of the patients of which had control of their disease. And it appeared, compared to historic controls, that survival was higher in patients receiving combination immunotherapy. Group at MD Anderson also looked at combination Ipi-Nivo, saw a response rate close to 20%, and overall survival high in the 19% range, 19-month range. So this is very promising in terms of combination immunotherapy. Currently, within the field, there is a discussion of whether single agent immunotherapy is overall survival is inferior or similar to combination immunotherapy. The issue with combination immunotherapy, ipilimumab plus nivolumab, is there's a high risk of side effects. And given that the response rate is still low, many patients may not benefit from treatment, and that unfortunately results in side effects in those patients. Now, there are new options for uveal melanoma. Clinical trials or clinical protocols are the way to study and gain access to new treatments. The purpose of clinical trials and clinical protocols is to show that a new treatment is safe and effective. It's conducted at cancer centers with expert clinicians, nursing, and data management expertise, and it's the best way to access new and up-and-coming therapies. It turns out that uveal melanoma is a unique tumor. As I mentioned, there are some specific mutations that are associated with uveal melanoma that include GNA11 and GNAQ mutations. This results in signaling through protein kinase 3 and through signaling through AKT3 and MAP kinase pathways and multiple other pathways that result in stimulation of the tumor to grow. Initial studies looked at a drug called selumetinib, which is an inhibitor of MEK. And in this, initially, there were some promising clinical data, but in a randomized data, unfortunately, selumetinib did not meet its endpoint, and there wasn't a significant improvement in overall survival. Another drug called darovasertib is in development, which targets a protein kinase C. This drug was recently published in a phase 1 showing a reasonably high response rate. However, there was some concern about short interval for resistance to develop. Darovasertib is currently being studied in an ongoing clinical trial where it's combined with a drug called crizotinib. And in this study, we're seeing a higher response rate with a large number of patients having shrinkage of tumor up to 30% of patients with a partial response. In patients who have not received any prior therapy, the overall response rate has so far been published as 50%, and hopefully this will continue to be observed, although this data is still very early and we're still waiting for data to accrue and to find out how durable these responses are. In terms of darovasertib, there are upcoming trials. Currently, the trial that's open in the US and at Princess Margaret is only available for patients as a first-line option, and the number of slots is quite limited. In the next year or so, there will be a new trial that will randomize patients to either receive immunotherapy or the combination of darovasertib and crizotinib. And in this study, patients who are not eligible for tebentafusp will be eligible for that protocol. There's also some exciting neoadjuvant data that is being investigated, and a study to use in patients who have who are at the time of their eye diagnosis require a nucleation will be studied in a clinical trial with an attempt to shrink the tumor in the eye, which may allow for preservation of the eye following treatment. An additional type of clinical trial under investigation, as I mentioned before, is a bispecific similar to tebentafusp that targets PRAME, and there have been some early clinical trial data released. This study is hopefully to come to Princess Margaret in the next 6 months, and hopefully in a few other sites around Canada. This has resulted in clinical responses not often seen in uveal melanoma, but very encouraging in terms of clinical responses seen in uveal as well as other cancers. Additionally, the the responses can sometimes be durable. So hopefully this will result in additional options for patients. Moreover, there is continued interest in the concept of tumor-infiltrating lymphocytes. This involves infusion of T cells that are derived from the tumor. This is where a patient undergoes surgery to resect a tumor. The tumor is then incubated in vitro in the laboratory, where T cells are grown out and then are expanded to large numbers and then infused as a therapy for patients. At the National Cancer Institute in the US, clinical trials showed an encouraging response rate in patients with uveal melanoma of about 35%, and many of these responses were durable. However, additional data is needed to learn whether this is a therapy that is going to have long-term benefit for patients with uveal melanoma. There is a trial soon to be opened in Canada, and I think currently open in the US, sponsored by a company called T-Bio, and the clinical trial is called Starling. And this is an approach where tumor-infiltrating lymphocytes are obtained from a patient's tumor, and then the tumor-specific lymphocytes are expanded using dendritic cells, and then an improved product is infused for patients as a therapy. This will be a very involved approach where patients will be identified early. A biopsy will be obtained to sequence the patient's tumor. Then a tumor harvest will occur several months later, and then the product will be generated for infusion. Patients receive chemotherapy and an inpatient admission, where patients then receive infusion of the product plus aldesleukin or high-dose IL-2, followed by further immunotherapy with anti-PD-1 therapy. So quite an involved type of treatment that might be most appropriate for younger patients as opposed to patients who have comorbidities or other issues that might make this treatment difficult. So in summary, while metastatic uveal melanoma is a devastating and life-changing diagnosis, we finally have treatment options. Standard therapies can result in long-term clinical benefit. Much more work, however, is needed to identify the best treatment for the patients at the right time. Clinical trial protocols and participation in these offer the best way to access new developing therapies. And I'd like to thank all of my colleagues who have worked with us over the years, and I'm happy to answer a few questions.
Thank you, Dr. Butler. That was a wonderful session with lots of reasons to give us hope. We do have some questions from patients. So here is the first one. Why are there so few clinical trials available for metastatic OM patients in Canada?
Well, I think the main reason that there are few trial options available in Canada is because that there are only a few trial options available overall. Certainly, there are some trials which are being developed in other countries where the trials are being and the new treatment is being developed, and usually they won't come to Canada until those initial trials are showing promise. I think that it's important that we are able to show that patients in Canada are happy to participate on trials and make it possible for new trials to be brought to Canada. But in general, I think we need to increase the number of clinical trial investigations across the board in all countries in order to increase options for patients here at home.
Thank you. Here's another question. Will ctDNA soon be used to track disease? And is there a role for using ctDNA in some centers?
The answer to that question is it's in development. I've spoken with colleagues in the US who have access to the Natera Signatera assay and have been disappointed on a per patient basis on whether the utility of that assay for treating their patients. But this is really anecdotal. I think it's really early stages, and we're really not sure what the role of ctDNA will be in the near future. I think in the far future, it definitely will be important. And I think it's something that's under further development. For research purposes, we are collecting samples, monitoring patients' blood, but it's not something that we have developed that is being used in real time for the management of patients. But I think it is definitely the way of the future.
Thank you. Here's another question. How do you understand the risk of metastasis? Does it affect different groups of people differently? Does it always go up after diagnosis?
So the best way to understand this question is at the time of the eye diagnosis, it's important to consider the tumor biopsy. This can have significant help in counseling patients and to understanding what their risk is for the future for these patients. Currently, in some provinces, the tumor biopsy test is funded, and a score can be provided to patients so that they know whether their tumor has higher risk or lower risk. That is not the case across the board, and we are advocating to try to make this happen for all patients. Another way to ask this question is, which test is the best test? Is the Castle test the best test because it's being used in the US and is more expensive, or is the cytogenetic test or impact genetic test the best test? And the answer to that is it's not really clear. I think either test can be useful. In some cases, centers will get both tests, but there really is a limited amount of tissue available, so choosing one or the other is the best approach. At Princess Margaret, we use the impact genetics test, although we are advocating to Ontario to fund this so that we can have universal access, and also are working with our molecular lab to try to do the test in-house so that it is not something that province has to pay an outside company to perform.
Thank you. And here's the final question. What clinical trials are currently available to patients in Canada? Where and when?
Well, I think it's important once you develop metastatic disease to discuss with your oncologist whether you would be appropriate for clinical trials, and to look at all of the options. The best strategy is to try to go somewhere where all of the treatment modalities, liver-directed therapy, systemic therapy, are offered, and to review with your physician all of the possible options. There are many clinical trials in phase 1 early development are available across the country. Those can be considered. Additionally, centers that have specific protocols or drugs that are showing promise with uveal melanoma can be considered. But I think it's important to balance the needs of the clinical trial with your own needs as a patient and a family member, and it's important not to lose sight that balancing all of those concerns is important. And once you come up with a treatment plan, all of us in the uveal melanoma patient advocacy as well as treating community can help you look at the options that make the most sense for you. So with that, I really thank you for your time and appreciate your attention. Take care. Bye-bye.
Thank you very much, Dr. Butler. We really appreciate your time and your patience with our questions. And now back to Candace.
Hi, everybody. I want to thank Dr. Butler for such an excellent presentation. Thanks so much for taking time out of your super busy schedule to prepare such a comprehensive overview of metastatic uveal melanoma. That was fantastic. And now we will have a 5-minute break and we're going to resume with Monica Tan.
Okay, welcome back, everyone. I'm just going to wait for a few people to join back in, but we are now on our third session for today, which will be led by Monica Tan. Monica Tan will talk about wellness tips and tricks with us. And Monica is a social worker at TELUS Health Private Practice, as Candace has mentioned earlier. Now, I will let her introduce herself and we are going to jump right into her session. So, Monica, I will let you share your screen and the floor is yours. Thank you so much.
Thanks, Jasmine. Okay, let me just get oriented. Okay, just sharing my PowerPoint now. And here we are. Okay. So it's my pleasure to be presenting today with you. And my name is Monica, and I'm a social worker based in Toronto. And today we're going to talk about how to cope with the psychosocial experience of being someone with ocular melanoma or being someone close to someone with the disease. I have 12 years of experience as a crisis counselor, a supervisor, and an EMDR therapist in private practice, specializing in working with traumatic events, anxiety, and depression. I also have experience as a caregiver of my brother James, who was diagnosed with cancer in 2018. So I just like to do a quick check-in with the group. There was a lot of information provided over this weekend, and I'd like to take a few moments to share, if you're comfortable in the chat, some emotions that came up for you over the weekend, if you're comfortable. And again, there's no right or wrong answer. Oh, thank you. So it looks like my audio is having some difficulty. I'm actually on a headset. Let me turn off my headset. Maybe my headset is the issue. Okay, is this audio better? Okay, it's better. Okay, great. Okay, so you may be having some mixed feelings, and that's completely normal. And if you're not sure what to do to cope with these mixed feelings, I'll be presenting some ideas on how to help yourself manage through as best as you can. And as a reminder, emotions are not inherently good or bad, and they are not absolute either. They're a way for your body to communicate that a need or a value is not being met. And I'm seeing here, great to hear the other people experiences. Absolutely. It's great to be in community and share with each other and not feel alone. Absolutely. Do your best to give yourself the space to feel everything and allow yourself to digest and integrate all emotions as a full experience. So moving on, it's important to get the facts, right? And how do we do this? So writing down questions and concerns and bringing them with you to see your healthcare provider. So being prepared. Also consider how much detail do you actually want to know? Some may want just the basics and leave the details to your healthcare providers, while others may want to know a lot more detail. So think about what works best for you. And again, there's no right or wrong answer. Bringing a family member or friend with you to appointments can also be helpful to remember what you hear. Perhaps you might want to also consider recording the appointment. Sharing a recording is another way to communicate to caregivers or family members whom you want to share the information with in an easier way. And lastly, getting organized with a cancer binder. I've included some examples of a cancer binder that will be sent to you in a resources page. A cancer binder may include, a calendar for tracking appointments and symptoms, some of your medical history, medication lists, your care team contact information, maybe your medical reports and your scans. And I've often heard patients also include positive notes and pieces of encouragement that they've collected on the way as well. And communication. So keeping the lines of communication is very important during this time. Having honest and courageous conversations with your loved ones and healthcare providers. So oftentimes tensions can rise if you feel alone or if people protect you by avoiding talking about bad news. Or you yourself may feel alone if you're trying to look strong and not share your feelings with others. If you start to tell the truth, it can create opportunities for meaningful conversations and to get support from one another. I think it's also important to note as well, based on some feedback that I've gotten from the patient consultation group, that there is a difference between men and women seeking help. Men tend to seek help later or less often when dealing with their diagnosis. And of course, there's lots of different reasons for this, maybe gender roles or cultural reasons or different expectations of men or women. So if you have men in your life affected by this disease, please encourage them to seek help as early as possible. And of course, finding your tribe and your village. It's really important to stay connected to support groups, maybe peer mentor connections, or tips from others who have been through your situation, whether it's through blogs or acquaintances online or friends and family members who have also had cancer. And don't forget also about professional help, like a psychotherapist, a social worker, an employee assistant program counselor who may be available to you through your work, or a spiritual advisor as well. And many of you may have young children in your lives that are going to be curious about cancer and what's happening. So I talk about it in the 4 C's, and there's 4 common concerns that children have when someone they care about is seriously ill. Can I catch it? So most kids are familiar with colds or flus or even COVID, and they know that they can catch illness. So reassure your child that cancer is not contagious. Explain they can touch the person, share food with them. Children also want to know, did I cause it? And you'll know if you have kids or you're around kids, they are very egocentric at times. They think that they're the center of the universe. They believe that their thoughts and wishes influence the world around them. And while this belief is natural and a part of development, it can cause them to feel responsible for someone else's illness. So giving them age-appropriate information and explaining cancer to them in a factual way will relieve them of that responsibility. And can I cure it? Children worry that they could have prevented the person from getting cancer. So reassure them again that the illness is beyond their control. And who will take care of me? When a guardian or parent is ill, children worry about who will take care of them. and it's natural to worry about the safety of important people in our lives. Reassure children that they will be looked after until they are old enough to take care of themselves. Specifically, naming people in their lives who could care for them after you cannot is important. Again, I know this is a really big topic, so I've included some more resources on how to talk to children about cancer in the resource page that you'll be receiving after the symposium. So next, I wanted to focus on some lifestyle choices that are relevant. And I know that, things like diet don't affect outcome much with OM. So I've chosen to focus on sleep quality and sleep quality enhancers. So first of all, why is sleep important? Poor sleep can make your mood, pain, and fatigue worse. It can also weaken the immune system and affect healing during treatment. It can also affect your memory and make it hard to think clearly. Some causes of sleep issues may include environment, for example, being in the hospital or maybe traveling and noisy and different, anxiety or depression, some pain symptoms, or even side effects from the medication or treatment. Talking to your healthcare team is very important, and understanding the cause of the sleep issue will allow you to create and select some more specific options to treat those sleep issues. These are some things that you can do on your own, so I've highlighted that below. Avoiding sugar and alcoholic drinks late in the evening. Although alcohol may help you get to sleep, it's actually quite disruptive to the quality of your sleep. Sugar can also be quite stimulating as well. Being physically active at least once a day, preferably in the morning or the afternoon rather than the evening, because again, exercise is stimulating in the evening. It's also quite common for thoughts to ruminate at night. So writing down your worries will help you manage them and keep your mind clear. Journaling has many benefits. It can be a way, for example, for you to kind of do a brain dump and externalize what's happening in your mind. It's also a great way to compartmentalize, right? So I will deal with this tomorrow, creating a to-do list and allowing yourself to deal with it the next day. It can also be a great way to cultivate gratitude and allow for a different perspective before falling asleep. If writing becomes too difficult, a good alternative is also voice recording. Avoiding using screen time 60 to 90 minutes before bed is recommended, as blue light can influence your sleep hormones and your circadian rhythm. Doing something pleasant and relaxing as a bedtime routine is another great way to ease into sleep. So things like reading a book or listening to a book, a warm bath, soothing music, maybe meditation or prayer, or even a creative outlook like coloring or doodling. And then also building a strong connection between your bed and sleep. So if you are having difficulty falling asleep for more than 20 minutes, get up and do something pleasant and relaxing in dim light, and then return back to sleep when you're sleepy. If you spend a lot of extra time in bed trying to sleep, you might associate time in bed being awake or even feeling frustrated, and we want to avoid that as much as possible. So bottom line, remember, bed is for sleep and sex only. And speaking of sex, your sexuality and fertility matter and can be affected by your cancer and treatment. So don't assume that your doctor or nurse will ask you about these things. You might need to start the conversation and advocate for yourself and revisit the conversation more than once along the way. And along the way, you may find that some things stay the same, and at other times things change, including having a different capacity for doing or being the way you used to be. And that's really hard for a lot of people. So I encourage you to let friends and family help you. This is a time to lean on them. For patients, if you're the type that has difficulty accepting help, or maybe you feel like a burden, just remember the same way how you feel really good and warm inside when you have the privilege and pleasure of helping the loved ones in your life. Your loved ones also feel really good when they can help you too. So know that it's a gift to your loved ones when you can accept help. And also for caregivers, cancer definitely affects the entire family and friends and loved ones. So if you're a caregiver, I encourage you to accept from your community too. No task is too big or small. Meals, grocery shopping, childcare, personal care, maybe transportation. Delegate what you can, and you can be surprised by maybe who shows up for you as well. So next, I'd like to get your reflection cap on and take a few moments to pause and reflect on this quote and how it applies to your journey so far. Most people are afraid of suffering, but suffering is a kind of mud to help the lotus flower or happiness grow. There can be no lotus flower without the mud. That's by Thich Nhat Hanh, who's a Buddhist monk. So now I'm going to pose a question, and it may be controversial to some of you here today. So the question is, have you experienced a positive life change as a result of your cancer? Have you noticed the lotus flower growing from the mud? And again, if you feel comfortable, you can enter your response in the chat. Curious about your reflections on this quote. Just going to give a few moments to receive some responses. Better relationship with my teenage daughter. Less materialistic. Now my focus is on people and time with friends and family. Compassion for others. Wow, there's lots streaming in. I live more in the present. No, this is 100% burden, no upside. And then diseases definitely help me develop more compassion and suffering for others. So absolutely, it goes the whole range, right? Definitely. Okay. And if that answer is a no, I want to acknowledge that that is a completely valid space to be in as well, right? People are in different stages and it's not linear. And sometimes it's a back and forth and up and down roller coaster. So wherever you are, it's absolutely okay to be. Okay. And yet I also wanted to introduce the idea of post-trauma growth, which is defined as a positive life change that develops from a stressful or frightening experience or trauma. The idea has its roots in many ancient thoughts and traditions, and there's definitely growing research that a cancer diagnosis can create post-trauma growth. However, I acknowledge it doesn't always do that for everybody. And I want to also talk about, just in case there are some folks who have a desire or know what to look out for. So what are some examples of post-trauma growth and how can I cultivate it? How do I watch for those lotuses and maybe those rainbows as well? So the first example is improved relationships with others. So living with cancer may deepen your connections with family and friends. It may also be easier to connect with other people who have experienced traumatic events. New life experiences. a cancer diagnosis may change your priorities. And this time in your life is where you get to review your goals, values, and priorities. So what is really important to you in your life? What are those activities that are most meaningful to you, that spark joy and light you up? This is a time when you get to say no, slow down, and cancel things that don't meet your priorities. And you've always had this ability to say no. However, now perhaps there is more urgency and intention backing you up. Now, I'm not telling you to all go quit your jobs, empty your savings account, right? However, you may shift in how you plan to live your life more fully. Maybe it's a career change or overcoming a big fear. I'm not sure what that is. However, it's a good time to reflect on that. You may have a greater appreciation for life. As you experience this new sense of vulnerability to death, this awareness may help you appreciate the world in new ways. Some people also describe a sense of personal strength, and they report having more mental strength and feeling empowered. This can come from feeling proud of what you have accomplished and lived through. Perhaps practicing relaxation techniques and talking with supportive friends and family can help you gain access to this personal strength and manage through the uncertainty that cancer can bring. You may also have more of an interest in expanding your spiritual depths in your life, such as practicing a religion or other personal spiritual practices. People often wonder more closely about those big questions during this time. What is the meaning of life? Maybe what happens to me after I die? And that often leads to contemplation about legacy and contribution. What do I want to leave behind? How am I making a difference in the world right now? How do I want people to remember me? And then taking action towards those things that you want to be remembered for. And now, with the theme of slowing things down and being present and intentional, I'd like to do a guided meditation together, and it's called Light Stream. And the Light Stream technique is used for processing an upsetting event or disturbing sensations in your body. And this will help you become more aware of where you hold stress in your body and also do something about it. So if at any time you want to stop during this guided meditation because of an uncomfortable sensation, definitely stop. I encourage you to do that. You have control over this, okay? So you can gently close your eyes or gaze softly in front of you, taking 2 breaths in through your nose and out through your mouth. Excellent. Now scan your body from the top of your head to your feet. Notice where in your body you feel a disturbance. If you notice more than one, pick the one that you want to focus on. Notice, how does that feel? If the feeling had a shape, what would it be? If it had a size, what would it be? If it had a color, what would it be? And now I'll ask that you pick a favorite color that you might associate with healing. imagine that this favorite colored light is coming in through the top of your head and directing itself to the shape in your body. And let's pretend that the source of this light is the cosmos. So the more you use, the more you have available. The light directs itself at the shape and resonates, vibrates in and all around it. And as it does, what happens to the shape, size, and color? The light directs itself again to the shape and resonates, vibrates in and all around it. And as it does, what happens to the shape, size, and color? As the light continues to direct itself to that area, you can allow that light to come in and gently and easily fill your entire head, easily and gently. And now allow it to descend through your neck, into your shoulders, down your arms, into your hands, and out through your fingertips. Now allow it to come down your neck, into the trunk of your body, easily and gently. And now allow it to descend through your buttocks, into your legs, streaming down your legs, and out through your feet. And may you be peaceful and calm, breathing in through your nose and releasing through your mouth. And when you're ready, you can become awake and present. And so now I'd like to take maybe a few shares, if you feel comfortable sharing how that experience was for you in the group chat. Maybe you're familiar with guided meditation, you've done something like that before, or maybe it's new or different. Okay, some found it relaxing. Thumbs up, that's the point. That's what we're going after. Calming voice, thank you. You're welcome. I appreciate that. Lovely to have a quiet moment. Yes. Okay, I think I've lost my chat a little bit there. If there are other comments, sorry, I think I might have missed something. Okay. Okay. And for those of you who might have had some difficulty with that, that's also okay. There's sometimes a trial and error process to figuring out what kind of relaxation techniques fit for you. So I've included other options for you to explore in the resources page through a free app called Insight Timer, where they have a lot of variety of different meditations to explore as well. Okay. So now we can move into the question and answer period. Feel free to reach out if you have any other questions at monicatan.ca. So again, thank you for your participation and sharing, and it always makes our presentations a little bit more lively and fun and learning together.
Okay. Well, I do want to just say thank you so much, Monica, for such a great presentation. Like you just mentioned, we are going to open the floor for questions from the group. And reminder, you can type your question if you feel more comfortable doing it that way, or you could turn on your camera and raise your hand, and we'll do questions that way as well, whatever you feel comfortable with. If we don't get to your questions today, we will email you at a later date. I will kick it off with a quick question, Monica, and just to see your thoughts. I know for me, when I was in treatment, and even after, sleep has become such a weird thing for me. We have a weird relationship together now. I felt that I got a lot of anxiety falling asleep because when I would feel really weak, it scared me a little bit. And I've had that issue moving forward. So what are your tips for really making a bed a safe space? And even if you're not in your bed, the hospital bed, how can you make those areas a safe space so you can have a good few hours sleep?
Absolutely. I think that's a great question. I think oftentimes what fuels that anxiety, right, or dis-ease or discomfort is what I call kind of like time traveling a little bit, right? You do time traveling in your mind. You might go into the past and you're like, oh, I should have, could have, why didn't I do this or that? Maybe that would have made a difference, right? Or it does some time traveling into the future, right? And you're kind of doing that catastrophizing, like I think Candace mentioned earlier. It's catastrophic. It's all the worst case scenarios that you're imagining happening. And so with things like relaxation techniques or mindfulness practices, staying here, anchoring yourself to the right here, right now, is probably one of the best ways to stay out of that time traveling and catastrophic thinking and feeling. Also, when you're at home or even in hospital in a different setting, right, bringing those comforting and soothing things with you so that you feel more comfortable, right, and having those anchors of comfort and safety, right? That's what we're all looking for in this time. It's, I want to feel safe and I want to feel like things are okay. So learning to teach your body how to feel safe with those relaxation techniques, mindfulness, and bringing cues of safety and comfort into your bedroom or wherever you're at can be very helpful.
Amazing. Thank you so much. We did get one comment so far here that just says, Monica, thank you. That was a wonderful presentation by Candace.
Thank you. Thank you, Candace. I appreciate that.
Hi, Monica. I'm going to ask a quick question. It's Kath.
Sure.
Firstly, it's my 20th year since my not so fun journey began.
Mm-hmm.
And I certainly wish I had had all these tools when I was first diagnosed, because the last 20 years has been actually quite grueling over my entire family.
Mm-hmm.
And for a lot of reasons. But I think the hardest thing for me as I progressed through this space was the guilt I felt around being a survivor when I was meeting so many others that weren't surviving, a lot younger than I was. And I think that was the hardest thing for me. I would have never thought there would be such a thing as survivor guilt. I would have thought as a survivor, I would have been, skipping through that mud. But actually it's become, quite hard for me. And I think the other part too is once I finished my treatment, I felt actually more alone and more anxious than during treatment, because I lost connect to my doctors and their nurses, which became a huge part of my family. And then all of a sudden treatment's over, they were gone. And then, when my family and all my loved ones went back to their normal life, my normal life was not normal anymore. It was this new life I had. So, I think for me, it was the guilt of survivorship when so many others weren't.
Yeah. So there's so many great things that you brought up and important things. So I guess let's start with the survivor's guilt, right? It was unexpected for you to experience that. And I think it's, like I said earlier, all emotions
are welcome, right? Guilt is not a good or a bad emotion. It's maybe signaling something is not being met or a value, right? And I often, talk about guilt as, it's a factual thing. Like it's more of, did I do something wrong, right? Guilt is about wrongdoing. So you might want to consider, like, did I do something wrong by surviving, right? Is surviving a wrong thing? And I think if a friend were to ask you that, right, or if a friend, were in your position, you would probably be saying to them, absolutely not. Surviving is not a wrong thing, right? I think it's important to just sit with that and reflect. Why might I be having that guilt? Maybe that guilt might be already there, right? There was a background of guilt. Often when I talk to folks, it's not just cancer that they feel guilty about, right? They might be feeling guilty in other areas in their life, and it's not about cancer. It's just this feeling or maybe a pattern that has pre-existed prior to this too. So, just, reflecting and journaling, I think, is really helpful, or maybe even talking to folks, right? Sometimes when we're in our emotion, it kind of grips us, right? And we sometimes need that support or outside perspective to help kind of shake us loose a little bit from, really examining, is this realistic or truthful, my thought? I often recommend cognitive behavioral therapy as a way to manage those difficult thoughts and feelings. And then you also talked about feeling more anxious and even, alone after the treatment, was done. And I think that really highlights, the element of grief and loss that happens throughout, your experience of cancer. There are so many different points of loss. And, I think that's a really important point that you bring up, Kathy, that grief and grieving is a really important part of this journey.
We do have another question here from Nigel that is asking how to develop more skills at not judging others or even ourselves, just accepting.
Sorry, can you say that again? You cut out for a moment.
No problem. So we have another question here from Nigel.
Uh-huh.
Wants to know how to develop more skills at not judging others or even ourselves, and just to be accepting.
Accepting. Oh, okay. Of your own kind of reactions or other people's reactions and responses. Okay, got it. Yeah, Nigel. I would love to know those two. I am guilty of that myself. I, often catch myself judging. And I think it's, firstly, just knowing it's part of our human nature, right? That when we judge, it's because of our values. We have our own, I call it game book, our own playbook, and those are our values. And we expect others to play by those same rules and have those same values. And yet we're all very different and diverse and lovely in our own ways. And so when people act or behave or feel differently than we do, we judge, right? And we might have anger towards them or otherwise. So it's just accepting that they're open to having their own value system and game book and playbook. And so are we. And I often recommend, any kind of exercises or strategies to develop self-compassion or compassion in general will help kind of alleviate those feelings of or thoughts of judgment of others and self. And when you can feel compassion, which is kind of, loving kindness towards yourself or others, it does compete with those feelings of judgment or anger or frustration with others. It's hard to have, two feelings at the exact same time. So I would suggest, looking up compassion or self-compassion exercises. And, with the judgment piece, I often find, even with myself, like what we're doing to others, judging others, is probably likely what we're doing to ourselves first. So instead of worrying about other people, if you can start to focus on yourself and how you're judging yourself and healing or calming that down with relaxation or compassion exercises, then you will more easily be able to cultivate that for others. And on the flip side, sometimes, you might be able to have compassion for others more easily than you are for yourself. And so you might want to start with, just, doing your best to gradually offer yourself more compassion as well. Thanks, Nigel.
Amazingly said. Thank you. We have a comment here by Kathy that just says, thanks, Monica. I don't think it helped that when I was first diagnosed with melanoma, there was a stigma that it was because of bad sun behavior.
That's also true. Yeah. And I think yesterday they studied that, and, there didn't seem to be much of or they weren't able to find a correlation with that, or, maybe pointing towards earlier sun protection at younger ages, but they weren't conclusive about that. Yeah.
Absolutely. We do have another question here. How would we know the right time to seek professional help with our struggles?
That's a depends question. It depends, right? It's so personal for everybody. I think some signs might be that you kind of feel like you're hitting a brick wall, right? You've done as much as you can on your own. Maybe you reached out to your loved ones and, friends and family, and maybe you don't feel like they understand you, right? Or what they're saying isn't landing the way it used to land, right? Or maybe you don't feel like you have somebody to talk to, right? So I think it really depends on your situation. However, probably when you really start to feel like your life is, it is going to be impacted by cancer. However, you feel like you're unable to kind of function in a way that is acceptable to you. I think it's a depends question. That's a tough one. Yeah.
No, that's well answered. We do have another question here.
Mm-hmm.
Do you have any advice for family or caregivers? Any advice would be appreciated. I do want to mention that also. It's hard when you're dealing with cancer. You don't want to be, like you said, a burden to your family. Sometimes you don't want to talk to them about any of that because you don't want to put it on them. So what's your advice for people on the other end?
On the other hand, for family and caregivers, I really wouldn't recommend anything different, right? I think I've said everything that applies to patients would apply to you as family and caregivers as well, right? The psychosocial experience of a family member or caregiver can be, just as devastating or differently devastating, but still devastating, right? And the stress and anxiety that they, might be experiencing as well can be, absolutely supported with the same techniques and strategies I've mentioned in the presentation. I'm not sure if I'm really getting at the core of that question. I don't know if the person who asked it wants to clarify a little bit at all. Maybe I'm not understanding the question quite as well.
Yeah, sorry. I was just asking, like, in general, if you have any advice for caregivers, but also, of course, like, we're very aware that as caregivers that we will never understand the circumstance and we'll never understand the space, and just like, I don't know, I think often you're kind of worried about coming across in a way that ends up like being clumsy or like offensive or entitled in some way, while we also just kind of want to make it clear that, like, the person in our life with cancer is never a burden, and we just want to help them as much as we can, even if we can't understand. So just like, if you have any kind of advice in terms of that, or just any insights are great. So what you said was still helpful.
Okay, now I understand a little bit more. Thank you for clarifying that. As caregivers and family members, we have the best intentions, right? We have an idea of how to help and support. And sometimes that lands and it hits the mark, and sometimes it doesn't, right? So sometimes just saying, I don't know, like, I don't know what you're experiencing, and really acknowledging it and saying, I can't imagine, right? Or acknowledging that gap. And then sometimes, getting direction from your person can be really helpful. So asking, like, what kind of support do you need? That can be helpful for the caregiver and family member to be just more specific, instead of assuming that, the kind of help that their person wants is what you're giving them, right? So maybe asking for clarification from your person.
Thank you so much. Okay.
Oh, actually, I had some thoughts as well. There are support groups for family and caregivers too, right? So definitely seeking your own support as well. Yeah.
Amazing. Is there any other questions from the rest of you on the call? Again, you can jump on camera and talk if you'd like, or you can put it in the chat box on the side or at the bottom of your screen. Okay. Okay, well, if we have, I think we have one more. Okay, so I think we have no more questions for now. Again, Monica's information is on the screen in front of you all. We will be emailing the resource page that she mentioned in her presentation. That is going to show all the resources she talked about. But if there's any more questions that you come up with later on, please feel free to email us. But again, a big thank you, Monica, and I will pass it on to Kathy.
Thank you again, Monica, for those great tips and tricks. I hope everyone here can take something from that and apply it to your everyday routine. It might not be today, it might not be tomorrow, but just put all of those little tips into your toolbox for when you will need them. We're now at the final session of the symposium, which is now when we're going to start talking about what patients and caregivers need from Ocumel Canada moving forward, and what needs you have that aren't being addressed. At Save Your Skin, we pride ourselves in being patient-focused, patient-led, patient-run. There isn't anything we don't do at Save Your Skin without hearing from you. I know when I was first diagnosed and started the foundation, I created the resources that I would have needed in that moment. But I know now in 2023 that the needs are different, that melanoma and ocular melanoma is changing on a daily basis. So that means that the patient's needs are changing along with those. So this is where, honestly, I'd love if your cameras are on if you feel comfortable. And similar to before, you can type in the chat feature at the bottom of the screen. I say you could raise your hand, but Jasmine, I don't know how that works. I'm not that tech savvy. If you have a question and you're okay putting on your camera, you can ask live, and I am going to be taking notes because I want this to be big picture. If Save Your Skin had $1 million and there was anything we could have created for you to make this muddy journey, how about that, Candace? I'll give it a new name, a little bit easier for you or your caregivers or your loved ones. This is when Nigel and I would love to hear from you, because that gives my team the opportunity to create new and innovative resources for you. So I'll open the floor.
And again, you could do it in the chat box if you feel more comfortable, or you could turn on your camera, raise your hand, and just speak. We're open for discussion and love to hear what you all have to say.
Just maybe to suggest to Kathy and others that if you do want to put your hand up and form any kind of lineup, just go to the bottom of your screen under reactions, and you'll find there the opportunity to put your hand up. Et aussi, si nous avons des francophones ici, parlez-nous en français, nous travaillons en 2 langues.
So I see, Ted, you have your hand up. If you'd like to unmute, you're free to ask your question.
Turned my video on, but doesn't seem to be connecting.
Yeah,
But
we've got
anyway,
you.
Great. You know, I was at a eye appointment in advance of my Avastin injection next week. This is in Edmonton. And I happened to be in a room with some other folks who were all waiting for various tests. And it turned out we were all there for the same reason, to see Dr. Weiss. Now, what was kind of unique about that was that there was 5 of us there. Most folks had a friend or a family member with them. But all 4 of the other folks were just recently diagnosed, and 2 of them were having surgeries, brachytherapy on Monday. So they're all extremely nervous, and of course they had 100 questions for me because I was kind of the 4-year veteran in the crowd. And obviously the complexity and the uniqueness of this is such that someone can't really give you specific advice, but I realized, and they we chatted for about 15 minutes in between our appointments, and they were so incredibly reassured by some of the things I was able to share with them about my treatments over the years. One girl came up and said, "Oh, you're my Christmas gift today, because you," and she was having surgery on tomorrow, and it just helped her. So I thought back to my time when I was diagnosed, and like so many of us, there's just so little information, and there's nobody to talk to, and I know that somewhere along the way we have to do a better job as early as possible, as early as people want to get connection with other people with this disease, because it makes such a huge difference. Thank you.
No, absolutely, Chad. And in the beginning days of Save Your Skin, we were trying to figure out how patients needed to be connected, right? Did they want a support group live? Do they want virtual support? Because everybody's different and everybody needs those resources and support at different times. So we sort of created everything as best we could. And for us, what's really important is that the patients sometimes have to remind your treating physicians that Save Your Skin is here. I know a lot of you don't know me as well as my cutaneous patients do, the hundreds and thousands of them. But we hope that patients are at least getting a card at that original diagnosis, so they can connect with an organization like ours that then can connect the patients throughout, Canada. I think sometimes we're each other's best support. When Monica asked what had changed, in our lives, what I have met is, what's changed in my life is I've met the most incredible people, the people I never would have met if I had not been diagnosed with melanoma, and I had not met Nigel and moved into the ocular melanoma space. So I totally agree. I always hope that the physicians across Canada, all of them know us. Some do, maybe not all. So, if there's a way you can help us even, when you're going to your appointment, seeing if they know who we are, that would really help. Because honestly, I think most of us would say the same thing. If we had been moved to a patient advocacy group, or given contact for a patient advocacy group in that initial diagnosis, whether we went there or not in that moment, I don't know. But at least it would have been another resource in our toolkit that we could have pulled out when we needed it. And not only that, in Canada, we as patients get to be part of the drug approval process. Like Nigel thanked everybody that was part of a patient survey that we did when the TEBI came in. And that's why, honestly, I think we saw TEBI come so quickly into Canada. The submissions and the input we got from patients was outstanding. And yeah, we saw that drug turn around very quickly in a process that usually takes, 18 months to 2 years. So the patients are instrumental in everything we do.
Thanks, Kathy, and thank you, Ted, too. That's one thing that we try so hard to do, to get in contact with people as early as possible, hopefully even the day that they receive their diagnosis of primary, or even worse, metastatic disease. I did see one patient comment in our Facebook group that it was the night nurse in at Princess Margaret who said to them, you know, there is a Facebook group that you could join and you might find some support in there. And it was really helpful to her. I have no idea how the night nurse knew about us, but if there's any way that we can spread that knowledge in doctors' offices, in the hospitals where patients gather, that's something that we want to know how to do better. So thanks a lot, Ted. That was fantastic.
Could I just make a follow-up comment? And perhaps I got something when I was diagnosed in 2019. I don't know. The challenge, of course, is it's so overwhelming at the time, and you know, you might just skip through it and not notice. And so anything that can be done to make it more reoccurrent or more, you know, we go to the same location every time. I'm going every 90 days, and it would be great to find a way to get this group out there so it's constantly in front of people, so that they discover it at one of their meetings along the way. That's just a thought anyway. Thank you.
Candace, you've got your hand up there.
Yes, just second to what Ted has said. I think it might be helpful if there's some way that we as patients can help when we're visiting either ocular oncology or our general oncologist, because there are people, I receive messages really often from people who somehow just Google metastatic uveal melanoma or uveal melanoma and they find me. And I get messages from them who, of course, I'm happy to support and help in any way I can. But I think that there's obviously something missing in this department. And at first diagnosis, it would be nice if they were aware that these resources exist to help them. They don't seem to be aware. Perhaps we can leave some kind of postcard or something that they'll put out at the hospital so that people can pick it up and be aware that the resources are there.
And I think we've got, you know, quite a bit of work still to do, you know, because ocular melanoma was relatively new to me, other than I've known Nigel for my whole life, I think it feels like sometimes. So there's a lot of players, right? It's the same in the cutaneous space, right? There's ophthalmologists, you know, there's testing now that needs to be done. But, you know, I can't emphasize enough the importance of patients reaching out to us in those initial diagnoses, because we don't just help with emotional support and resources. We raise money to help patients financially. And when, you know, we were meeting with Dr. Weiss in the beginning days, and I found out that, you know, patients in Alberta get a test free and patients somewhere else don't, that's an issue that we behind the scenes can take on. Right? There are instances where we have actually paid for testing for patients, and we can do that. But we need to kind of solve the bigger issue and making sure that those tests are universal across the country and they're done in that moment, you know, not 3 or 4 months in. So again, that's why as soon as those patients are diagnosed, if we can hear from them, it helps us sort of look at the issues that they're having behind the scenes and see how we can correct them for the next patient coming through.
So maybe there's something that we as patients can do at our visits, speak to the physicians and see if we can leave some kind of written material there so people can see, even just a website, a Facebook group, anything, so that they know that the resources exist, because they don't seem to know. Right?
Absolutely, Candace. And we did actually produce a contact card about 3 years ago. And we sent many, many copies of the card to the 4 treatment centers. And we asked, you know, if they would be kind enough to distribute them to patients. I think you're really encouraging us to do that again, to include maybe a little bit more information. The Facebook group didn't exist actually when we did that card. And then maybe patients like you and Ted can say, if you send me 100 of those cards, I will take them in and I will ask my doctor personally, say how important it is to try and, if they're diagnosing a new patient, for example, say, please let that person know, and actually also give them, my contact information. I'd be very happy to try and help them. We're not, Kathy talked about how many players there are. There aren't many players in ocular melanoma. It's such a rare cancer. I think we can do this. I think if we all pull together, we can get that information and we can say to our doctors, it's really important that you help us get this information out so people can be in contact with each other.
Agree 100%.
Yeah, and Candace, that's a good point, because in the original days, the little brochure that we made, we sent to the cancer centers. They won't put them out. We already know that, right? They have to go through some protocol. But when we send them to a Dr. Butler, Dr. Weiss, Dr. Wepler in BC, they can distribute to their patients. So, but even though, Marcus Butler is one, and our oncologists are pretty well known to us and us to them, but it's more building that database of ophthalmologists, right? People that actually are seeing, in that primary setting, and making sure we get that resources to them as well. That's where you can really help us build that database.
We do have a hand up from Jitan Mori. Jitan, if you'd like to pose your question, the floor is yours.
Hello, I'm very happy I finally found this group. I'm being diagnosed five years ago. And I was just recently actually had my doctor's appointment in Vancouver with Dr. Payton and saw my ocularist. So I was focused with the same intention to create this bridge, what they would know about existence of Ocumel. And surprisingly, my ocularist was not aware, and she was very open to receive all this information. So I left actually my handwritten card. Surprisingly, I talked to my doctor, and I felt she was quite reserved. Sometimes it said it works, sometimes it does not work. So I felt very kind of unusual reaction. She was aware about Ocumel Canada. So this is my feedback from my very recent visit with my doctor 2 weeks ago.
Nigel, do you want to comment on that?
I have to be very reserved in my comments on that, but your intervention, that's the most beautiful thing, and thank you for having the courage to do it. I think if we keep doing it, it will make a difference. And if we point out how important this is, it will make a difference. And I just keep thinking of how we've talked about the terror we felt when we were first diagnosed. That's exactly the moment that you need somebody to hand you a card with contact information on it. So let's keep trying. We can do this together.
Okay, anybody else?
We do have just some comments that have been made in the chat. I don't know if you have had a chance to see them, but it seems like a reoccurring theme that people talk to their doctors asking them to have material, and a lot of them say no. So, which is quite unfortunate, but I do see we have another hand up here by Laura. Laura, you can pose your question whenever you're ready.
Hi, everyone. Can you hear me okay?
Yes.
Yeah.
Hey, sorry, I'm on my phone here trying to make sure it doesn't fall over. I guess, given that we have such a small, because it's a rare form of cancer, we have a small data set, I'm always sort of wondering if the statistics are changing as we get further into this, with there being so many more types of therapies and things like that. And the statistics have always been so jarring because you know, how much data have they had over time? And then even, sometimes our age of diagnosis and things like that, complicating factors. And it doesn't seem like new statistics get reissued as time progresses. And it's even difficult to find any differences in statistics between populations like the US, Canada to Australia. So as a patient, it's really difficult to navigate that and to feel like, even though we hear lots about different types of treatment coming out over time, we don't know if the impact on survival rates is being realized yet. So we're hopeful, but it'd be lovely if there was some sort of publication that got reissued on the regular, like every 5 years or so. Just like you mentioned, you got the contact information out to doctors or, the 4 treatment centers. If we ask them every 2 years, put out another poster on your wall, or like send them out to everyone on this list and we'll sneak up with thumbtacks on the poster board. Yeah, so it's just one the way to hear more about routine statistics, and that sort of thing.
Absolutely, Laura. Thank you for saying that. It's obvious because you're seeing Candace and me here that the statistics are changing, where people are definitely living longer, even with metastatic disease. It takes so long for the data to accrue in a scientific manner, and I think that's what you're saying. But anecdotally, I'm in touch with literally hundreds of people who have been surviving for 4, 5, 6, 7, 8 years with the disease. So, one thing that occurs to me is that if you're in the Facebook group, you'll notice that I occasionally mention the vision registry and entering your information in there. And there is an annual review of the data in there. So if you're keeping it up to date, that would be a very early way of looking at the data that is a lot more encouraging than it used to be. So have a look at the vision registry, see if that's something that would work for you. And I think maybe, Kathy, you and I can talk about if there's any softer way of getting at that data for our population.
Well, firstly, I want to kind of add a little bit there. You're absolutely right. That's the hard thing when you're starting as a patient to look for statistics. Statistics are only once a trial is completed, that's when all the statistical data starts loading up, right? And just because ocular melanoma is new into the treatments, right? Like the TEBI, what happens, it will be years before we see any really updated statistics on that, whether it be in Canada and the US. But that's another reason why I always hope that patients in that initial diagnosis, again, are given a card to connect with an advocacy group. Because I was taken actually nicely aback when Dr. Butler started his presentation, because I remember 15 years ago when Dr. Butler and Dr. Smiley started a presentation to us cutaneous patients, and we were told we had a 1 to 2 year survival rate, if even. Well, now 20 years in, it's 75% of us survive beyond 20 years. I mean, they don't even, there's no statistics even anymore. So that's what always worries me when patients start looking at statistics and numbers, because it's literally just that, a statistic and a number. And I think Marcus actually said that in the opening of his presentation, right? You are a patient, you are different than everybody else on the screen. And so again, that's why I think it's super important that, patients can connect with other patients, because then you get to meet Nigel and Candace, and realize that numbers are numbers. I do notice that Rob put a comment on the chat too about a resource. I hope everybody can see that. It's Wellspring, Alberta. And I have to admit, we've used them a lot. We've worked in conjunction with them on a number of initiatives over the years at Save Your Skin. They have wonderful resources and programs that you can take part in. So maybe, you can check that out. We can send that link to you after the session is over. If you can't get it off the chat there, please take a look. There's a lot of really good support services out there. Okay, any more questions or hands up or comments, suggestions? You're our experts here, so.
We have one comment that just came in from Candace that just says, I've completed the healing journey 1 and 2 at Wellsprings, Toronto. Very helpful. So that's great to hear. We also have some more resources, one from Maria. A Cure Insight also has a patient registry, and she shared the link in the chat for everyone as well. And we have copied that. So thank you. Okay. Are there any more questions? Again, we are ahead of schedule, which is always nice, but we would love to answer your guys' questions while we all have you here.
And if you can't think of any now, please feel free to email myself or Nigel or Jasmine. Honestly, all comments and suggestions are very welcome. So, please let us know if there's anything we can help you with.
Yes, and I think that's the important message to everyone. We're open for comments. This might not be the day that you have a brilliant idea about how we could help more people more often. But as you develop an idea, anytime that it occurs to you, please make contact with us. That's the work that we do day to day.
Ted, do you have one more comment?
And it's maybe a simple question, but it just strikes me that Ocumel Canada, an initiative of Save Your Skin, doesn't have the word ocular melanoma or uveal melanoma in it. And I find it a bit confusing that it's not there. And I'm just wondering why it's set up that way.
Maybe I should take that. Ocumel is actually shorthand for ocular melanoma. So it's there, but I know that it's very brief. But hopefully that's partially an answer to your question. Ocumel stands for ocular melanoma.
And Ted, that's something kind of we're working on behind the scenes as well, is the vocabulary being used, right? Because even our physicians, some are using ocular melanoma, some are saying uveal melanoma. We had a roundtable out in British Columbia, I guess about, oh my God, Nigel, it's about 6 months ago. And last November. And at the end, one of the caregivers looked at us and said, boy, after hearing all these stories, I wish my husband had been diagnosed with ocular melanoma and not uveal melanoma. And we were trying to tell her. So Nigel and I have discussion a lot, and I have it with the physicians because they switch the terminology. And I know when I was diagnosed, the switching of terminology just added to my already anxious unknown, right? Like, was I cutaneous? What is metastatic? So that's a discussion we're having. And, even Nigel, you and I might want to, discuss how we use the wording around the ocumel and the ocular a little better too.
For sure.
Yeah, I appreciate that. And certainly now I'm more educated, but it was a process. And certainly, again, kind of going to my earlier comment, is the people at the beginning are so confused. And the abbreviation, though I understand why maybe it's come to be, and I don't know what the solution would be, but I mean, it's not obvious to someone who's not a year or two into this. So that's just a comment back to you guys. Thank you.
No, and I appreciate it, because I have to tell you, after last night, I think I texted Nigel and said, holy smoke, I've got a million ideas running through my head. Because firstly, this was our first, symposium. And I think I learned a little bit in cutaneous that sometimes it was better to educate patients and their caregivers and upstream it than going out and training our physicians, because there's so many of them. But after seeing all the presentations yesterday, I think there's a huge opportunity for us to take those video recordings. And what I'd like to do behind the scenes is see how we can start educating more of our treaters with those videos, right? Marcus Butler, Dr. Weiss, Dr. Kramer are really, really exceptional. If you're lucky to get to one of those three, you're very lucky. So I think we could use these opportunities to use those 3 video recordings as training sessions for treating physicians.
We have a hand up here for Laura. Laura, whenever you're ready.
Given that, like the earliest sort of, I guess, detection that there is a nevus to be further investigated or monitored, usually comes not from one of these 4 treatment centers, but from optometrists and things like that. Is there a way to get, like, I don't know, the distribution list for the equipment that is used to scan the back of the eye, and use that as, you know, a distribution list to share materials with as time goes on? Because given that the wait and see approach was preached for so many years, and now a little bit more early intervention, depending on the size of the tumor, is sometimes recommended, people might have outdated information or not fully be up to date because it's what they learned. And maybe 5 years ago, it was the best knowledge, but now it's something else. Should we be doing targeted campaigns in that regard?
Candace, did you have a comment for that or a different question?
No, I have a comment. It's just speaking to what Laura just said, which is huge. When my diagnosis was really delayed, and I mean really delayed. I had gone to my own local optometrist about 5 times in the course of 5 months with really obvious symptoms. He had no clue what was going on. And the scary thing is, I was also sent to an ophthalmologist who probably should have seen the tumor or the orange pigment, and he didn't. And I was finally diagnosed, and I'll always wonder if that almost year-long delay resulted in Mets, but that's not my point. My point is, when this happened, I had reached out to the Ontario Association of Optometrists. So there are provincial associations of optometrists, and there is the Canadian Association. And I really tried. I promised I would never out the optometrist, because I mean that it could have been anyone. There are many of them who miss the diagnosis, and it resulted in a lot of hard work and effort on my part and zero interest whatsoever on their part. And I always wondered, did I do this wrong? Like, the first person I spoke to had even alluded to the fact that maybe I could come and speak at a symposium and just talk about the symptoms I had. Sometimes people have no symptoms, and just try to educate the optometrists. And I had no luck. So I'm wondering, maybe, and it's amazing that Laura said this, maybe there's something that a larger organization can accomplish. I myself, with the Ontario Association, it was such a waste of my time after just thinking that I could help. They really were not interested whatsoever. And I don't know why, and I don't know what I did wrong, but it would be amazing to be able to educate local optometrists on this.
Well, I think there's ways though, because
I'm sure there are.
All these physicians need credits, right? They get credits every time they attend a symposium or melanoma conference or whatever. So they get credits for that. So my job is to go back and figure out how I work with a Dr. Butler to find out how those credits, we could use some of our materials, like those videos, as a potential credit. I'd ask everybody on this symposium to help me a little bit. And if, let me know who your ophthalmologist an oncologist are. I'm pretty sure I'll know the oncologist, but it lets me start to build a little bit of a database. And then my team, and if you have any other connections that you've emailed through the Canadian associations, whether it's within your own province or Canada-wide, if you can send that in an email, it would help us start to build a database. That's what really helps us. It took us a while in the cutaneous space, but it's no different than it is today in the ocular melanoma space. In the cutaneous space, we had 2 treaters right in the beginning, and we use those 2 treaters to mentor the rest. Now we have a melanoma task force across this country that's about 40 deep, and they mentor all the new up and comers, right? So we use the oncologist, the dermatologist. We have the potential to do the exact same thing here now, and you're the people that can help us do that. So if you can let us know who those people are, we might have them in our database, but we might not. And that helps us start the process.
Thanks, Kathy. And I could also add that, we have made a start with this. And for the past couple of falls, we've been running a campaign called #IGetDilated. And we have worked with the optometry colleges and associations in BC and Alberta so far. We have reached out to the others. We've not been successful yet, but we will get there for sure. And we do a poster with a patient talking about, their story. One thing that's a problem for us is the cancer is so rare, and the people who, the point of entry is really optometrists. And we have 6,000 of those across Canada. So it is a large group. But when I was first diagnosed, my optometrist, who was retiring after 30 years, had never actually seen it before. And she thought it was a retinal tear, not a tumor. So education in the colleges of optometry, yes, for sure. Let's try working on that more. Please join in the campaign, I Get Dilated, when you see that on our page in the fall. That's the work that lies ahead. Candace?
Yeah, so I'm not sure if I overtook Laura's question, but it just made me think of this. So I'll leave it with Laura again to say if I've gone on a tangent, but can you imagine the impact to have access to the paying members? Obviously, there are a ton of optometrists that aren't members of these associations, but even they get a newsletter to just have a little blurb with a short video. It doesn't have to be the whole 45 minutes or however long it was, a short video saying, did you know? And at least it's on their radar for the next person who hopefully they won't fail. Anyway, sorry if Laura, that's not exactly what you meant. I'm going to mute myself now.
No, that was a fantastic discussion. I appreciate that. Thank you.
Okay, well, I'm going to hand it over to Nigel, and if there aren't any more questions, so he can update you on a few of the things that we do have moving forward. I'm really proud of already where Ocumel Canada has come. We developed the Ocular Melanoma Task Force of physicians, right, representing the whole of Canada. So we ticked that box off. We're having our first ever symposium. We're ticking that box off. We know we've got a lot of work to do, but I know there's a few cutaneous patients on this call. For those of you who know me, there's never a task too big or too small. There is never an ask too big or too small from a patient. I have a 1-800 number that you can call anytime, day or night. Everybody, my cell phone is probably on most doctors' office walls. If they won't take my brochure, I just etch it on a wall in there. You can call me any time of the day or night, any day of the week. So Nigel, I will hand it over to you for closing.
Thanks, Kathy. So we're about to close the symposium, and I can't tell you how happy I am to see so many people joining us over the past 2 days for this first ever ocular melanoma patient and caregiver symposium in Canada. We hope above all that you know now deep down, you are not alone. You have a team on your side and by your side. Please feel free to reach out to us whenever you need help or support. Just a couple of last things, I promise. Please don't forget to visit our website and Facebook group, which you will see on the screen shortly. You'll all be emailed the recording of this symposium once it becomes available. The videos and resources mentioned today will be available on our website in the upcoming days. May, which is just around the corner, is Melanoma Awareness Month. So you will see information too about 3 exciting events coming up. On May the 4th, please consider joining us for our fireside chat, which will focus this time, for the first time, on ocular melanoma. May 19th is #IPatch4Day, along with our friends in the US and the UK. We raise awareness of ocular melanoma by wearing an eye patch. Hopefully you will post pictures of you with your eye patch in the Facebook group and elsewhere on your social media channels. And finally, on May 27th, we have an in-person Metro Vancouver patient and caregiver roundtable. If you're anywhere near Vancouver on that day, May 27th, please come and join us. You'll see information about that also on the screen in a moment. Our dream is eventually to meet all of you in person, wherever you are in Canada, over the next while. So that is all. Thank you for joining us for the past 2 days, and we look forward to doing this again. Merci beaucoup. Bye-bye. Au revoir. And back to my friend Kathy to close.
I'm only going to take a couple seconds. Firstly, thank you everybody for attending. It's a weekend and here we all are. So thank you for coming. To all our sponsors again for helping make this possible. Now, I know we don't like to use the word journey, so I hope I'm not offending anybody, but I can't thank Nigel enough for his vision. And I mean his vision for Ocumel Canada. Nigel and I met years ago. He was my first ocular melanoma patient. We've become very good friends. He has sat on our board, and his vision is what pulled all of this together. So Nigel, a big hug from me, because look at where you have brought us all today. I also want to thank Jasmine and Taylor from my Save Your Skin team. We wouldn't be able to do this wonderful work without you working behind the scenes. If I had had to organize this, we would have all had to pull out our old rotary phone and dial in. And I think this is pretty cool technology. So again, thank you everybody for attending. I hope you have a great end to your Sunday. Jasmine, back to you.
Well, thank you, Kathy, Nigel, and every single one of you who has joined this call today and everyone who helped create the symposium. I want to remind you again, once more, we will be sending you the recording of the symposium. It will be up on our YouTube channel in both English and French, as well as our website, both in English and in French, and emailed to both groups as well. As well as all the resources we discussed today, and mainly that one pager Monica mentioned. If you have any questions or would like some more information, please feel free to email me at jasmine@saveyourskin.ca. Again, that's just jasmine@saveyourskin.ca or info@saveyourskin.ca, and I will point you to the right direction if I cannot answer your question. We are now done, but the information mentioned previously about all our events will be on the screen for the next 10 minutes, which includes our websites, email address, Facebook group, and all the upcoming events, like I just said. That is everything for now. Again, a big thank you for all of you that has joined our call today, and to our entire team. Have a lovely rest of your Sunday, and bye-bye.